So, as my friend Dr. Ameya just said, that what I will be talking about today is basically about a debate that was done in the ADA. And this was a very interesting debate where two very, big scientific people from the world, from across the world, they discussed on two things. Like there was Dr. DiFronzo, who was discussing on the combination therapy, who was speaking for the combination therapy, and there was Dr. Nathan, who was speaking against the combination therapy. He spoke for the sequential, addition of drugs in the treatment of diabetes. Now, we do know that there has been a concern about which is the best way to go forward. So what Dr. DiFronzo presented was that he said that when you look at the ominous octet, we are aware about the pathophysiology of diabetes being better understood today in terms of 11 pathophysiological pathways, and rather it has gone up to even more these days, with one or two even coming up even more. But then he says that when you're targeting the ominous octet, how will it do if you're just targeting one pathway? So what he said was that when you are treating a patient, it's just not enough to correct the HbA1c. It's important that you also target the other areas of the pathophysiology so that you prevent the cardiovascular complications, you prevent the renal complications, you prevent the atherosclerotic complications, you prevent, you bring about an overall well-being of the patient rather than just targeting the HbA1c. He also said that when you're doing it in a sequential manner, which was initially done, you add a drug, doesn't act, and then you add on something else, and then that doesn't act, you add on the third molecule. That is a pathway towards the treatment to fail. He said that this is not the correct way to be, because we have seen across many studies that this leads to a bad metabolic memory. This leads to a situation where most of the people, and he cited the UKPDS, he said that here the molecules were added in a sequential manner, and almost 65% of the people who were a part of the treatment of UKPDS went on to insulin by 15 years. And this was a result of them not being treated very aggressively from the word go. He also cited two other studies that have been done, one which was done under him, which is known as the VIC study, wherein the combination therapy was compared to the sequential therapy, and better results were obtained with the combination therapy. And he said that his idea of a combination therapy includes a GLP-1 receptor agonist, an SGLT2 inhibitor, and pioglitazone, as he places it. And he also spoke for the other combinations, in sync with the targeting of the different areas of the pathophysiology. Now, to combat this, what Dr. Nathan said was that he had three points to say. First of all, he said that if you're adding a combination from the very word go, number one, you do not know which molecule is giving you what kind of benefit. So you do not understand one molecule in its total perspective for this particular patient. Number two, he said that the side effects come in together and you do not know to which to attribute. So you have, three drugs put in together and somebody has nausea and vomiting or something else, and you don't really know which drug is doing it. Thirdly, he said that it is costly to put in a combination, because the difference in the cost when you're putting in a combination from the very beginning as compared to a sequential therapy is marked. So these were his points. These were the points that were raised by the two great minds, DiFronzo and Nathan. If we try to understand this concept in our own perspective, from the perspective of our Indian patients. Now, when we look at the data, we understand today that our patients are slightly different from the patients of the West. We have diabetes, which is coming in earlier. We have cardiovascular complications coming in earlier. We have beta cell failure, trending in earlier in our patients. We also are conscious about the difference in the phenotype of our patients. Metabolic memory has been very strongly understood over the years. And today, I think the vast majority of our doctors in India and across the world agree that it is the concept of stepping up therapy one by one does lead to a series of years wherein you are not keeping the patient under control, and that has led to a number of complications subsequently. So majority of the patients, the doctors who are treating patients in India, there has been a meta-analysis of what they think, and there have been questionnaires that have been put forward to understand the perspective of doctors, and most of the doctors have actually agreed that in our setting, looking at combination therapy is probably a better step forward. because of all the data that we have together. Combination therapy, we have seen the verified trial, wherein we've seen the benefit of combination therapy, wherein the two molecules added together vis-a-vis them being added in a sequential combination did result in better control in the combination therapy group. So given the data that we have together, given the understanding of our patients with diabetes, given their differences and their tendency to have a beta cell failure very soon, I think from my own perspective, after having heard both these people debate on these two issues, my personal opinion, and that the opinion of a lot of my colleagues, is also that probably in our context the combination therapy stands better. Now, which two combinations you're going to choose, or which three combinations you're going to choose, you'll have to basically look at the pathophysiology and choose a combination that targets most of the pathways of the pathophysiology, so that you're not only giving the patient a benefit of the HbA1c reduction, but you're also looking at giving them benefits in terms of cardiovascular protection, in terms of renal protection, in terms of protection from heart failure, in terms of protection from the other atherosclerotic complications. So all these things put together, I think today where we stand, we will definitely, most of us, I would say, would definitely favor combination therapy, because that, as we know, the Franzo's theory that has been put forward is basically attacking the diabetes from the very word go, and not allowing it to seed its destruction in the various organs before we kind of attack it. So that was it. I think this has been the basic discussion. We do agree. I mean, of course, we must agree that the data with the studies that have looked into the combination therapy in comparison to the sequential therapy is limited to small number of studies, because most of the comparisons between the combination therapy has been with the monotherapy. They've not been with sequential therapy. So we do have one or two studies wherein, like the VICT, wherein we have seen a comparison with the combination and the sequential, but data indeed is small. It's limited to small number of patients. The duration of the studies have also not been very long. So these are the drawbacks when we are talking in favor of combination therapy. But then again, when we look at what we have achieved with all our knowledge, we do realize that majority of our patients, 50% of our patients still have an HbA1c of more than 7%, and 25% of our patients have HbA1c of more than 8%. So this has been more seen with the the sequential therapy, and that brings us to this point wherein we need to decide whether we go aggressive from the very word go, or whether we give it a little bit of time, whether there's a clinical inertia in initiating a combination therapy. My vote would be for a combination therapy, certainly. Of course, understanding where the patient stands, what combination you would want to put in. Though Franzo did say about taking away metformin from the very initial combination therapy, I think a lot of us might not agree with that. We would rather keep in metformin and add on other molecules, maybe an SGLT2 inhibitor or an GLP-1 receptor agonist, which would act at the other areas of the pathophysiology. So that's it.